session is themed Equity in Healthcare Practice Models and is titled Equitable Access to Poisoning Care in India, Challenges and the Way Forward. We would like to invite our speaker, Dr. Ravikar Ralph, for this talk. And we would like to invite Dr. Anand Zakaria to moderate this session.
So it gives me great pleasure, and I'm really proud to introduce my student, Dr. Ravikar Ralph. Ravikar did his MBBS in CMC. He did his service obligation in the CSI hospital in Bangalore, then came back to do his MD. He joined our unit in the year 2015, and in the last 8 years has set up what he is going to talk about today, which is about the Poison Control Center and how it displays some of the ideas of equity. Ravikar is a bright clinician. I mean, if you see him analyze the case, you will understand, you learn certain things, and very good teacher. In the last 8 years, he has been involved in setting up the Poison Control Center with other members of our team. This center handles calls from across the country, round the clock, and it's one of the 9 poison control centers which are WHO recognized in India. He's also involved a lot in snakebite work and snakebite mitigation, and in advocacy for this, both at the national and at the international level. He's on the Government of India committee to frame guidelines for snakebite mitigation. He's been involved in writing the regional action plan for WHO Southeast Asia and on the WHO technical committee for snakebite, among other committees. So he's really one of the leaders which is coming in the field of poisoning, and I'm really happy that he's here and to say how a clinical department can try and address issues of equity.
Thank you so much, sir. Now, this presentation is divided into 3 main sections. Firstly, I will be speaking about the current scenario of poisonings and snake bites in India, especially in the context of healthcare access that is available to victims of poisonings and snake bite. The second section will basically discuss how poisons information centers can fill the gap that exists in this area and improve the quality of healthcare that is being delivered to these patients. And then we will discuss a few suggestions on how we can strengthen the existing models that have been started. Can you all hear me now? Okay. Am I audible now? Okay. So moving on to the first section, what exactly is the problem that we are dealing with? Now, as we all know, India has one of the highest poisoning and snakebite death rates in the world. And the statistics are such that every 5 minutes, 1 Indian dies of a snake bite. And this cumulatively results in nearly 60,000 deaths every year, which is the highest number of snake bite related deaths in the world. Every 5 minutes, 4 Indians are disabled, even if they survive the snake bite incident. Each day, 2 Indians die of pesticide self-poisoning. Every week, 2 sanitation workers die of toxic gas inhalation, something that has been highlighted by speakers yesterday as well. And this entire issue is worsened by the fact that India has one of the lowest doctors per 1,000 population ratios as far as other countries are concerned. Now, this is a study that was recently published looking at the time that doctors spend at consultations in primary care settings. And as you can see, the average time that a primary care doctor is able to spend in consulting in India is only 2 minutes. And that is mainly because of this doctor-patient ratio. Many doctors in primary centers are overwhelmed by the numbers of patients that they need to see, and as a result of which they are unable to spend more than 5 minutes with every patient. And understandably, this is a problem that worsens in emergency care settings where there are a large number of sick and unstable patients that they need to see. We also know that 80% of India's doctors actually work in urban areas. And in the context of poisonings and snake bites, this is a very difficult situation because it is the rural centers which are the first point of care for more than 70% of all snake bites and poisoning incidents that occur. This situation is further worsened by the knowledge gaps that exist amongst junior doctors, especially in primary and secondary care settings, in being able to diagnose and effectively treat poisoning and snakebite victims. Now, this is a study that was done in 2008, which basically administered a pre-designed questionnaire that had 12 key essential elements on snakebite treatment to 600 primary care doctors in 5 states of India. And these were the results that were found. None of the doctors were able to get more than 30% of the correct responses in these 12 key essential questions that concern the management of snakebite. And 70% of doctors felt that just 2 puncture wounds were enough and sufficient as a criterion to give these patients antivenom, irrespective of whether or not they had features of envenoming. Now, this is another case from CMC, which again exemplifies this problem. This is a 42-year-old social worker from Chittoor who presented with nausea, vomiting, and epigastric pain 30 minutes after he intentionally ingested an agrochemical agent. He was taken to a secondary level health facility at 1:30 at night. The doctor saw him, his vitals were stable, but he was found to have erosions in his oral cavity. His systemic examination was normal. Now, the relatives had taken along with them the container, which, as you can see, was an agrochemical. It's a herbicide called glyphosate. Now, this junior doctor who had been given this bottle was really not familiar with this compound. And so, like most of us do, he took out his phone and he typed the name of this agent. And he found, as you can see in those circles, that glyphosate is an organophosphorus compound. Now, had this doctor had the time to actually click any of these links on this page, he would have realized that all organophosphorus compounds are essentially organic compounds that contain phosphorus in them, and that not all organophosphorus compounds inhibit acetylcholinesterase. These are 2 examples. One is phosphomycin, which is an antibiotic, but actually it's an organophosphorus compound. Zoledronic acid that we use for osteoporosis is also an organophosphorus compound. The same is true for glyphosate. Though glyphosate is an organophosphorus compound, it does not inhibit acetylcholinesterase. It is mainly a herbicide which is mixed with a surfactant called polyoxyethyleneamine. And glyphosate works by inhibiting a pathway called the shikimic acid pathway, which only is found in plants. And as a result of which, its mammalian toxicity is quite low. So the clinical effects that are exerted by this mixture of compounds are largely because of the POEA rather than the glyphosate itself. Now, because POEA is a surfactant, it causes mucosal ulceration, and in very large doses, it can impair cardiac contractility, it can increase pulmonary vascular resistance, and in some cases, patients can develop a cardiogenic shock. Gastric lavage is a relative contraindication, and the management is supportive. The antidote is not atropine. Now, getting back to our case, the patient received 6 vials of atropine over 1 hour because the doctor was concerned that he would develop features of an organophosphate poisoning, and he would find it difficult then to manage the patient. He was concerned that the hospital did not have ventilatory equipment, and he wanted to prevent the onset of poisoning. So he ended up giving this patient aliquots of atropine over 1 hour. This patient subsequently developed atropine toxicity, and he was referred to our unit for further management. So in this instance, it was the antidote itself that caused more clinical problems than the agrochemical that was ingested. The other component, which is a huge challenge, is challenge because of poor connectivity in remote and rural settings. This is a newspaper article which shows how a mother had to carry the body of her child for 6 kilometers after a snake bite, and the child ultimately succumbed to the snake bite. Now, this is not a very old report. This is from this year, And this is happening in a state that has very, very well developed healthcare systems. We also need to remember that this is not an isolated case, because up to 60% of all snakebite deaths in India happen before patients reach hospitals because of a number of issues, but connectivity is also a very, very important issue. Healthcare access in poisoning and snakebite victims can also become a challenge during chemical disasters. Health systems that are already fragile decompensate when there are huge chemical disasters. We need to remember, of course, that Bhopal is the world's worst industrial disaster when there was a leak of methyl isocyanate, which occurred in 1984, 3rd of December. More than 2.5 tons of methyl isocyanate were released. More than 200,000 people were exposed. There were 8,000 deaths, of which 2,000 people died immediately, and 50,000 people had long-term morbidity. Now, this is something that has not significantly changed over the years, and lax industrial safety norms persist even today. This is an example of something that has happened recently. This is the styrene gas tragedy, which happened in 2020. This was a leak from an LG Chem polystyrene plant, which uses styrene gas, which is stored as a pressurized liquid. The gas leaked because of faulty equipment, and a vapor cloud was created which spread over 3 kilometers. At least 11 people died within 24 hours, and more than 1,000 people were injured. This is another incident which was not covered in the news of an arsine exposure that occurred at a lead battery recycling plant in Mangalore last year, where 3 workers at a battery recycling unit were exposed to a colorless gas while incorrectly handling lead waste, while not wearing any personal protective equipment. All of these people developed severe intravascular hemolysis and severe renal injury. And because they were working in a lead battery plant, the hospital that they went to assumed that it must be lead and treated them for 5 days or more for lead poisoning, rather than be able to detect that it was arsine which was causing this illness. These patients were subsequently referred to us. They required renal replacement therapy and prolonged hospitalization. Now, this is a problem that is set to worsen because the chemical industry is only set to expand further. There are more than 130 million chemicals that are described, and it is impossible to know the clinical aspects of each of these chemicals at any given ready instant. More than 1 million people in the world are at risk of hazardous chemical exposures, and up to 1 million die every year globally. Now, each of these injuries, deaths, and disabilities are easily preventable. And this is a map, this is a graph that shows chemical industry outputs by region. And as you can see from the brick red or brown bars, this is the output from the BRICS countries, including India. Chemical industrial output is only set to increase and double by the time we reach 2030. And all of these, given our industrial norms, will only result in more accidents and industrial exposures. So what could be possible solutions in the context of such a huge problem? Now, there may be many solutions, but one that has been shown to help and work in many countries which have similar issues are poisons information centers. Now, poisons information centers are specialized units that provide poisoning related information. And this information can be of many different types. This information could be information on diagnostic aspects of poisonings and envenomings. For instance, identifying an agrochemical or identifying a poisonous plant or a venomous animal, the toxic dose of different compounds, their elimination half-life. The information could also be on first aid and management. What are decontamination strategies that can be used, the antidotes that can be used, their doses and side effects, as well as enhanced elimination strategies. Poisons information centers also provide information on chemical safety and emergency response, and in addition to this, play a role in needs-based research, training healthcare workers, community outreach, and contributing to regulatory interventions as well as policy initiatives. Now, these poisons information units are the most basic, vital, and integral component of any poison control system. And in many parts of the world, these poisons information units are variably combined with a clinical toxicology facility and a toxicology laboratory to create these larger, more integrated systems, which are called poison control centers. One such center is the CMC Poison Control Center. We have 3 components. There's a poisons information unit, we have a clinical toxicology unit, and an analytical toxicology laboratory. The Poisons Information Service is 24 hours. It is active 7 days a week throughout the year. It can be accessed via toll-free number through email and WhatsApp. This is linked to a clinical toxicology unit, which helps with managing complicated patients with toxicological problems, interdepartmental consultations. We also have a substance use disorder clinic. And all of this is supported through an analytical toxicology laboratory, which is in collaboration with other departments, especially clinical biochemistry, the neurochemistry laboratory, and clinical pharmacy, where we are able to offer rapid immunoassays to screen for psychotropics, CNS depressants, drugs of abuse, qualitative tests like dithionate, as well as the ICP-MS facility, which is very useful for heavy metal estimation, because we do get a number of patients with chronic heavy metal poisonings as well. However, as I mentioned before, this presentation is mainly going to focus on our work through the Poisons Information Center. Now, this is the workflow at our center. Once a call is received, it's taken by a physician who is there on call 24/7. He collects relevant information. We have an in-house computerized database because of the volume of calls that we receive. So all of the details are transcribed into this. And what we do is the information is then provided and the call is reviewed. We usually try to call back doctors who call us after 12 hours, 24 hours to ensure that they do not need any further information that might help in managing their patients. The information that we provide is through a database. It's a products database called ToxBase, which contains information on more than 20,000 different chemicals as well as poisonous plants. We also use the international chemical safety cards to help with queries on chemical hazard of different compounds and safety information. Each of these call records are reviewed and checked for accuracy and completeness by senior physicians, and then they are stored, and then there is an yearly report that is generated showing trends of different poisonings, snake bites, as well as various other incidents. Now, we were initiated in 2019, and over the last few years, we have received nearly 15,000 calls. This is basically data showing how the number of calls that we've been receiving has constantly increased. And the previous year, we received nearly 7,000 calls. Currently, we receive calls from all across India. This map actually shows the various places from where we receive calls, and the intensity of the color in this map is proportionate to the number of calls that we receive. Of course, we get the most number of calls from Tamil Nadu, but we also get calls from other remote parts of India, especially the northeast of India, from places like Jammu and Kashmir, and we are therefore able to support the care and management of snakebite and poisoning patients from all across India. At our center, the vast majority of calls that we receive are from physicians. Only 7% of calls are from the general population, and that is why our center is mainly run and the calls are mainly taken by clinicians, because most of these calls have components that require some amount of clinical experience to be able to be answered in a satisfactory manner. The other important finding from our data is many centers that call us are situated in remote areas and they lack advanced laboratory infrastructure. Nearly 60% of all calls that we receive are from primary and secondary care hospitals. And this is very important for us because these are centers which do not have advanced laboratory facilities. So it is not easy to just open a database and then just give all the information that is available. For instance, a database may suggest that an arterial blood gas analysis has to be done for a poisoning, but that may not be available at that center. So it's very, very important for us to tailor the information that we give and adapt it to the local situation, and then be able to share information that can be implemented in those small hospitals. One such bedside test that we commonly suggest, this is just an example, is a test for methemoglobinemia, which is becoming very common as far as agrochemical poisonings are concerned, usually triggered by the ingestion of these biological or environmental pesticides, which claim to contain only natural agents, but they end up containing a number of nitro group containing compounds which can trigger very severe methemoglobinemia. Many of these hospitals do not have arterial blood gas at all. These are patients who come very sick in respiratory distress, and so it's mainly through clinical examination and using the simple test where, as you can see, a few drops of blood, if placed on a gauze piece or a filter paper, will reveal the dark chocolate brown color that occurs once the ferrous in the hemoglobin molecule gets oxidized to ferric, producing methemoglobin. Some sometimes if the blood is extremely dark, it becomes difficult to differentiate between chocolate brown blood or violet or dark blue blood. In these cases, we advise that a little bit of oxygen just has to be passed onto the filter paper. And if it is venous blood and the oxygen and the hemoglobin has not been converted to methemoglobin, it converts into oxyhemoglobin and the blood turns bright red, but there is no change that occurs in cases with methemoglobinemia. The blood remains dark and chocolate brown. Now, nearly equal number of calls that we receive at our center are to do with poisoning and snakebite events in children and in adults. But if you analyze the cause of the incident, you see that a vast majority of poisoning incidents in children are all because of accidental poisonings. But this is the mirror image in the case of adults, where an overwhelming majority of poisoning incidents are because of intentional harm. So these are the two main causes that we deal with: accidents in children and intentional poisoning in adults. Now, these are the 5 most common exposure categories. Most of the calls that we receive at the center are to do with agrochemical poisoning. The next common category is industrial and household chemicals, pharmaceuticals, and then bites and stings and plants and mushroom poisonings. Now, this is just, we have a very, very wide number of and many different categories of poisons that people call us with, but these are just some common categories. As you can see, amongst agrochemicals, most calls number at least 25% are to do with pyrethroids. As you can also see, the number of organophosphate related calls are few. This might be because organophosphates are not being commonly used, but may also be that doctors are familiar with how to manage organophosphate poisoning, and they tend to call us for other agrochemicals that are a bit more unfamiliar. Amongst industrial and household chemicals, most calls are to do with corrosives and irritants. Pharmaceutical calls are to do with psychotropics, unlike Western countries where paracetamol is the most common pharmaceutical that is ingested. And of course, for bites and stings, most of the calls are to do with snake bite and venoming. Now, we have been able to follow up small number of these calls up to 48 hours just to look at the outcomes. And as you can see, in 71%, so close to 70% of cases, the patients actually became well. They were cured and discharged at 48 hours. 3% succumbed to the illness, and then smaller percentages were referred to other hospitals, discharged against medical advice, or continued to remain admitted at 48 hours. Now, in addition to this, our poison center has also been able to help with a number of chemical emergency incidents. We are able to provide emergency information to the public, to health providers on containment measures, in first aid, decontamination, stabilization, antidotal therapy, which can now be disseminated via the electronic media. We are also able to coordinate and guide the transfer of patients, especially with industrial chemical exposures, from peripheral centers to the CMC toxicology unit for advanced management. So in addition to the 2 incidents that I mentioned previously, where the Poison Information Center was able to help both in the styrene gas tragedy as well as the arsine poisonings, we have also been able to, in the past few years, been able to help with information in an incident of an ammonia gas leak in 2022, and a hydrogen sulfide leak from a tanker in Surat again in 2022. So these are incidents that are very common, but they usually are things that people are not aware of. In addition to this, we also help with training healthcare workers and community outreach. We organize CME and CNE programs for nurses and for doctors, and all of these are mainly designed to help strengthen the knowledge of people who work in primary and secondary care centers. We focus on diagnosis and management of poisonings, venomous bites and stings, chemical incident response, as well as emergency preparedness. We have also been privileged to work with the Government of India in collaboration with the Ministry of Health and Family Welfare to train state nodal officers and primary healthcare workers in the management of snake bites. And over the last 1 year, we've been able to actually help states that have special problems in terms of snake bite management: Assam, Jammu and Kashmir, and Tripura, which have a number of different challenges when it comes to managing snake bites. And we have been able to reach out to close to 1,000 doctors across the state to help strengthen their approach to managing and diagnosing snakebite envenoming. We also help with rural community awareness and training programs. The focus here is the safe storage of agrochemicals, snakebite prevention, and first aid. Last year, we were able to cover 8 villages around Vellore and Chittoor, and we were able to train close to 700 community members in first aid for snake bites. We also help with training programs and sensitization programs for school children and the primary and secondary school children level. And that's mainly because if you look at the news as well, most of these accidental incidents of snake bites that occur tend to occur in very small children. So we want to actually sensitize them on general principles of safety first aid. We use child-friendly illustrations and concepts. As I said, the focus is on general principles of safety and first aid. We've been able to visit 31 schools and reached close to 5,000 school children over the last year. We have a very good team which comprises of a toxicology nurse educator who actually leads each of these educational interventions. She also helps in educating patients who are hospitalized with poisoning and snake bites before discharge, because you would be surprised to know that there is not a very high rate, but there are incidents where people who have been admitted with a snake bite go back and then come back again with another snake bite. And in a study that was done in Bangladesh, this was 6% in their community-based study. So it is very, very important to ensure that people who are admitted for care are also trained in snakebite prevention, adequate first aid before they are discharged. And this is one such example of a toxicology nurse educator speaking to a patient on aspects of snakebite prevention and first aid. She also plays a very important role in conducting group educations for patients and their relatives in CMC, sensitizing them on poisoning and snakebite prevention. Last year, she was able to conduct again close to 700 sessions and reach nearly 15,000 people in the hospital as well. Now, how do we take this forward? There are a few important steps that are needed. The first important thing is India needs more poisons information centers. As Dr. Anand mentioned, for a country with 1.4 billion population, there are less than 10 poison centers that exist. The WHO suggests that for a population of 10 million people, there must be one poison information center. And to sort of make this this information a bit more stark, you can see the number of poison information centers in a place like Europe with a comparable population compared to India. So we do need a number of poison information centers to come up. The existing poisons information centers also need to work together. They need to collaborate so that data that is being generated on poisoning events, snake bites in the country can be shared. Data sets with larger volumes and high frequency of observations can be compiled. This will help us map geographical trends, identify at-risk and vulnerable populations so that targeted interventions can be planned. It will also help map temporal trends in exposures so that we can predict potential outbreaks. It's also very, very important to strengthen the clinical knowledge of health providers in primary centers. The first important step, of course, is to strengthen our existing curriculum. We need more toxicology teaching hours, greater clinical exposures, which, as all of you will agree, is not available in toxicology for our medical students. Secondly, we need distance education modules, more CMEs, workshops, which are mainly aimed at primary and secondary health workers. And of course, poisonings can be very complex events. We do need to also focus on tertiary care facilities, develop focused clinical toxicology, toxinology curriculums, which will empower doctors to be able to manage even more complex patients who have critical life-threatening conditions who require advanced care. So we need to develop a curriculum so that we can actually help create a group of doctors who are able to actually help treat patients with complex poisonings and snake bites. The curriculum has to be relevant to India. So in summary, there are a lot of disparities in healthcare that exist for victims of poisonings and snake bites in India. Poisons information centers can play a vital role in strengthening and improving the quality of care that is being delivered, but more numbers are needed, collaborative networks are needed if this response has to be effective across the country. Thank you.
So
I was working in Assam for many years.
Yes.
I think most of the snakes there are not, you can't give the ASV. So what is the strategy for hospitals there?
So that thank you so much for that question. That is a very, very important and relevant problem for most of the northeast of India. What is gradually being recognized, and we also have helped through some information that we have shared on the fact that unlike most of India, where there are 4 main venomous species that are medically important, namely the Russell's viper, the saw-scaled viper, the common krait, and the Indian cobra, the Northeast has a number of range-restricted species which are more akin to the species that are found in Southeast Asia. So, as Sir mentioned, there are a number of pit vipers. There are other species of kraits that are there. Usually what we advise, we do get calls from places in the Northeast as well. We have been able to handle and help with calls concerning the green pit viper species from there, the mountain pit viper. And what we usually advise is that if patients are not having overt clinical bleeding, because most of these are viper envenomings which cause hemostatic abnormalities, we tend to advise that the patients be managed conservatively and be closely monitored, because as you very rightly mentioned, the Indian antivenom products that are available are not designed to be able to neutralize the venoms of these species. And so we will end up actually exposing these patients to harm through the side effects of antivenom rather than do any good. On the other hand, if patients are having bleeding, then it is better, and if it is a clinically significant bleeding, it is then advisable to consider product support with FFP and other products rather than give them antivenom. If it is a very small rural remote center, what we usually advise is, even if patients are not having active bleeding problems, then we advise them to write a detailed letter and shift them to a center which might have support facilities available if the patient were to worsen, because these patients cannot be given antivenom if they suddenly worsen in a place that is extremely remote, and then to have to shift that unstable patient becomes a problem. So for species that are not the big 4, it is always advisable to avoid antivenom and manage them supportively. Also, from the policy aspect, because we have actually brought this issue up with the government of India, who has actually worked extensively on developing a national action plan for the prevention and control of snake bites. The government also is cognizant of the fact that there are different species in the Northeast. One, of course, are the pit vipers, but also other species like Rhabdophis subminiatus, the red-necked keelback, which again, their venoms are not neutralized by Indian antivenom. The government has engaged with a number of manufacturers to see if there are monospecific antivenoms that can be produced in limited stocks, which can then be used in the Northeast of India. It would not make economical sense to incorporate the venoms of these species into polyspecific antivenom, because this is not going to be relevant for other parts of India. So there are discussions that are going on to see if monospecific products in limited stocks can be created so that these patients can be treated for the specific species related envenoming.
There is one publication that paraspecific action can be taken into advantage if patient is so severe, there is lack of availability. So we can try.
Yes, sir. So that again is a very, very relevant point. How does antivenom have paraspecific ability? So that actually, as Dr. Bavaskar very rightly said, would tend to vary depending on different species. For instance, like Sir mentioned, there are a number of in vitro studies that have also been done, which show that as far as green pit vipers are concerned, belonging to the genus Trimeresurus, invariably the antivenom that has been developed against one green pit viper species does have some amount of cross neutralization and paraspecific action against other green pit vipers. That is experience that has been shared. However, this is not true for all species. For instance, we have recently been a part of a publication, as I mentioned, on a case of mountain pit viper envenoming, Ovophis monticola, where the snake had actually been identified by the treating doctors as the Russell's viper. The patient ultimately received 102 vials of antivenom over a period of 3 days. He continued to have clotting disturbances. He continued to worsen. And that is when they were able to actually link with us. This is an incident that happened in Nagaland, where the Russell's viper is not an endemic species. We were able to help with the identification of the snake. As I said, this was Ovophis monticola. This case itself shows clinical evidence that Ovophis venom is not neutralized by existing Indian antivenom products. There is also growing evidence both in Sri Lanka as well as other parts which show that the hump-nosed pit viper venom is also not neutralized by Indian polyspecific antivenom. And a number of people actually develop side effects of the antivenom and also continue to have the envenoming effects of the hump-nosed pit viper. So if you look at publications from from 2021 and 2022 coming out both from Kerala as well as from places like Manipal. They have abjured the use of Indian antivenom in proven cases of hump-nosed pit viper envenoming because it is of no use. So the concept that there will be paraspecific neutralization in every case may not be the rule. Paraspecific neutralization has helped with crate bites especially. So if there are bites by species of crates other than Bungarus ceruleus, which is a common crate, there is some paraspecific effect that does exist clinically. There are a number of reports that have shown successful treatment of patients with Bungarus fasciatus envenoming with Indian polyspecific antivenom. So this is not universal, but it can help in certain species.
Sir, a quick question. Since you had mentioned regarding a poison information center, could you just briefly tell us about the current existing manpower, since you happen to mention that a clinician is required to attend the call, and the logistic issues that are facing with the current dearth of adequate poison information centers?
Yes, thank you so much for that question. From the manpower issue, there are a number of issues that all poisons information centers face across the world. This is not different for Western or for other countries. There are common issues. One is, of course, funding, because most of these centers are not for-profit centers. We do not charge for any of the calls that we receive, and the work that we do is in addition to the clinical responsibilities that we fulfill. So we are very, very grateful and lucky to have received some amount of funding support from various agencies that has helped us set up infrastructure. We are very grateful to the Center for Pesticide Suicide Prevention in the UK for sharing Talkspace. And over the years now, Talkspace is also available for other centers for resource limited countries through the WHO itself. So there are ways that can be used. We actually initially started a poisons information center with pharmacists, PharmD specialists, but we had to sort of modify the workflow, and because, as I mentioned, a large number of these calls were from doctors, and it was difficult for pharmacists who are very who have a lot of experience with the therapeutic aspects, but it becomes difficult for them to give advice in an emergency clinical situation. So most of these calls, I'm very grateful for the team that we have. Most of the calls we have basically two people who mainly focus on supervising these calls. One is Dr. Mohan and Dr. Amit, and we have from the last 2 years been able to employ junior doctors who actually take, because we get nearly 45 to 50 calls a day, and it is difficult for any of us to then focus entirely on this. So we have been able to receive support to employ junior doctors who work full time on receiving the calls, but each of these calls are then discussed with consultants. And as I said, each of these records is checked for accuracy, completeness before it is signed off. Again, the other important financial constraints that comes is with an inquiries database. When we started, we had a pen and paper to record whatever information we were getting. But as the number of calls increases, it becomes increasingly difficult to be able to record and store this data. There are a number of commercial inquiries databases that are available, but they are beyond the reach of hospitals and centers in countries like India. We have again been blessed and lucky to have been able to develop our own in-house inquiries database, which is comparable to the systems that are available commercially. We are able to enter data in it. We are able to analyze the data as well.
Can you tell us something more about methemoglobinemia? I've seen was poisoning with low dosage of dapsone and some chemical which was used by the goldsmiths and also the dyeing industries.
Yes, so I would say that in our own experience, methemoglobinemia has been quite an unrecognized problem related to agrochemical poisonings in India. As sir mentioned, most of us link methemoglobinemia to medications like dapsone, as well as other newer drugs like pegloticase, rasburicase. These are drugs that are, if a person reads a textbook, these are drugs that come as causes of methemoglobinemia. But we have received close to 100 calls in a year where people ingest these, as I mentioned, biopesticides. And one of the great challenges, which this talk was mainly on challenges on equitable access, I have not been able to discuss challenges that poison centers face when they give calls. That's a huge topic in itself. One of the challenges is that a vast majority of agrochemical containers do not have details of the agents that are present within them. So all it says is biopesticide, or it says rat killer, or sometimes it doesn't say anything at all except for the trade name. So many of these are biopesticides, and I would like to say that that if you ever see some bottle that says a biopesticide or a growth enhancer, always think of nitro compounds or benzene containing compounds that are present within it. Most of these patients actually present with severe respiratory distress because, as I said, in each of these cases, the ferrous in the hemoglobin molecule is oxidized to ferric, resulting in the production of methemoglobinemia. And as we know, methemoglobin has a very strong affinity to oxygen, and it doesn't want to give up oxygen to the peripheral tissues. So what actually happens is there is a state of asphyxia or anoxia that occurs, and as a result of which most of these patients present with features of respiratory distress. The important thing here is that when you examine them, the chest will always be clear because this is nothing to do with oxygen diffusion. So the chest will be clear, the JVP is not elevated. These are people who develop cyanosis, and a very, very simple way of differentiating this, if a person has cyanosis, one is of course the filter paper test that can be done, but another test, if an ABG facility is available, is to look for what is known as a saturation gap. So a saturation gap is when you use a pulse oximeter, because of the cyanosis, there will be the pulse oximeter will show some amount of hypoxia. So the saturation will be, let us say, 88%. But when you do an arterial blood gas analysis, because the hemoglobin is still bound to, or the methemoglobin is still bound to the oxygen, the PO2 and the calculated saturation, which is the ABG calculates from the PO2, will be very, very high. So you will get a sort of dichotomous result where the ABG will show a saturation of 98%, but the pulse oximeter will show you a saturation of 88% or 86%. So if there is a saturation gap of more than or equal to 10, again, even if you are unable to estimate methemoglobin levels, you can very clearly make a diagnosis of methemoglobinemia. It is an imminently treatable condition. The antidote is methylene blue, which is given at a dose of 2 mg per kg IV over 5 minutes and 5% dextrose. And what methylene blue is able to do is it is able to reduce the ferric to ferrous and then restore normal hemoglobin. So those are some things that we need to remember about methemoglobin. The other important thing that we have to remember about methemoglobinemia, especially with drugs like dapsone, as well as agents like chlorates, is that there is, especially with dapsone, there is enterohepatic reabsorption and recirculation that can occur. So people can actually have methemoglobinemia, they can be treated, and then again they can have a recurrence of that methemoglobinemia as the drug again enters into the circulation. So it's very, very important, even if we've treated a patient for methemoglobinemia, to closely monitor them and look for a recurrence.
Well, just to conclude, I think that we've heard a few talks where the specialized units play a major role in supporting care, particularly at the primary and secondary level. The idea of we heard on day one about the flex unit, how it supports training for that poison across the state of Tamil Nadu. Poison Information Center provides a resource for care at primary, secondary, for training and for documentation and for advocacy. These are simple principles that different clinical units can take to see what is the role of a teaching department in a medical college for supporting more equitable access to healthcare. Thank you very much, Ravikar, for your presentation.
We would like to specially thank Dr. Ravikar, and we request Dr. Anand to felicitate Dr. Ravikar on behalf of the department. Thank you very much.